is a 54-year-old female who presented with melena on 28th Feb 2024, single episode, followed by on and off non-bloody vomiting with drop of hemoglobin from 10 to 7. Upper GI endoscopy done elsewhere. It shows a 3 into 2 centimeter pedunculated polyp with broad base on the posterior wall of D1 with overlying ulcer. ESTV was done there only. CT revealed an enhancing duodenal polyp of size 3.2 into 1.1 centimeter. And the plan is endoloop application and polypectomy. Over to you, sir. Dr. Binmoeller.
Well, such an interesting case. I'm just surprised not to hear anything about endoscopic ultrasound. Was an endoscopic ultrasound not done in this case?
Not done, sir.
I see. Well, I guess that probably would be where I would start, is first with an endoscopic ultrasound to better characterize this lesion. It looks like a subepithelial lesion. This is a double channel scope. You saw it used yesterday for removal of the leiomyoma in the sigmoid colon. I'm going to use it again. I think the double channel scope is vastly underutilized and underappreciated. Hence, it's really a pleasure for me to be able to emphasize its value in endoscopy. I think everyone should have a double channel scope. Now, there are many things you can do, obviously, without having a double channel, but it really is just giving you that additional channel. The only drawback of a double channel is it does have a wider diameter. So let's take a look at the lesion first. And there it is. And it looks like it's basically pedunculated. Just based on the appearance, the morphology, I bet this is probably a lipoma. So my bet would be, if we had a mini probe here, I don't think we do, mini probe, EUS mini probe. We have one in our unit. I use it all the time. The mini probe is no different than a catheter. Put it down, and then instantaneously, you don't have to have an echo endoscope, right? A dedicated echo endoscope. You can just put the mini probe down your working channel and switch on the ultrasound, and then you'll see this is probably going to be an echogenic lesion. And then you have your diagnosis. Now, if it's an echogenic lesion, it looks like a lipoma, the only reason to remove it is if the patient's symptomatic, and this patient had a bleed. And these lipomas very often bleed. They can get very long. Look at this one. It's like a cigar in the bulb extending down to the second portion, but it probably also flips out into the antrum as well. It probably pendles between both the duodenum and the antrum. So I think this is where the attachment is, the broad base. Now, how do you treat such a lesion? And I think we'll just bypass or skip doing the endoscopic ultrasound because we'd have to bring the ultrasound. We don't have it in the room right now. So let's just go ahead and assume this is likely a lipoma. Well, how would you remove this? Well, there are different ways you could do this. One option you could do is just throw a snare over it, bring it to the base, and just cut it off. And I think that's very acceptable. But one thing to remember is that lipomas are very vascular. They bleed very easily. You don't think of lipomas as vascular, but they are. Whenever I remove lesions on the IC valve in the colon, I tell the nurses, be prepared with the coag grasper, with Purostat, everything, because these bleed because of the fatty tissue in the IC valve. So one thing you could do then is you could inject epinephrine into the stalk, the base. It's very broad-based. And the epinephrine will do two things. It will constrict the blood vessels, but it also will shrink the pedicle itself. So that would be a good option. So, that would be certainly very reasonable to do. Now, because I have the opportunity of being here with you in Delhi, it's a chance for me to show you what I call incremental innovations. So these are innovations that are not disruptive. It's not like Axios, which I think really was disruptive in that it enabled us to do things we couldn't do before. But incremental innovations are basically just better mousetraps. It's improving devices that we already have, that we're already using, but they have limitations. Now, one of the devices that I also really love is an endoloop. And I got to show you that yesterday, but it's an opportunity for me to show you what I think is an improvement, because I'm still amazed that after decades, we still have only one endoloop. Imagine we only had one clip still, but today we have a variety of different clips. Clips have evolved enormously. We have clips that have longer distances between the prongs. We have clips with different kinds of teeth, right? So Boston Scientific has the Mantis clip. It has like a hook on the end, and you can grab, and the idea is you close it, and that hook digs into the tissue, and then you open it up again. Then you go to the opposite side when you're closing a defect, and then you hook this opposite jaw, the prong, into the tissue, and then you deploy it. That's an improvement. And then there's the DAT clip, dual action tissue clip from Microtech, which I use routinely in my practice in San Francisco. This is an amazing clip because what it does is it allows you to independently grab each of the margins. So it's like the twin grasper. So there's a post in the middle, and you open up the prong on one side, grab the edge, and then you close that, right? So you've got the one edge, let's say the distal end, and they are color coded. There's a gold and a silver, so you can differentiate. And on the handle, you can close the prongs relative to the post, independent of one another. Then you go to the opposite side, you open up the other prong against the post in the middle, and then you bring the two together. So these are all improvements, incremental innovations of the basic clip. But we haven't seen this happen with loops. And so I'd like to see this happen. So I have one idea for an improvement of the loop. So here you can see this loop. And so it gives me a chance to kind of show you how this looks. So Ashwani is with me on my right, just like yesterday. And today I have Assis on my left side. I've got a double channel scope. He's not going to do anything right now. But Ashwani, you can see that you can if you pull the sheath back, what it does is it opens up the loop, and the loop is mounted on a snare. And that's what gives the loop stiffness. There are little lugs on there that I created that mount the loop on the snare. Now the loop will snap off of the snare afterwards, but the snare is very stiff. So Ashwani, why don't you just show how you can open up in the stomach just to demonstrate for you. So go ahead and open up. So here you can see nicely how this loop is mounted on the snare, right? It looks like they're tied together. They are. There are little lugs there. There are little snap-on. It's a snap-on. And it is attached to the snare. So the snare is a scaffold that holds the loop nice and open. So it gives it the stiffness. The problem with the loop is the floppiness. It just flops all over the place. And then when you try to close, the tip usually flips up, and then you end up not being able to close over the lesion. So this is one potential solution. Yesterday, you heard about, this is from Dr. Puri, his idea about a loop with a nitinol wire inside. I thought of that idea too. The problem with that is that if you have wire, you can't cut through wire, but also there's the risk that you can conduct if for any reason there is a disruption of the coating, the plastic coating of the loop. The wire's on the inside in the core, so there's the potential if you're going to, for example, snare above the loop and the diathermy gets to that inner core, the nitinol, then you're going to extend the diathermy to the deeper layer. And that will not be good. So that's the reason why I personally abandoned the idea of stiffening a loop with an inner wire. But it's a wonderful idea. I just don't know whether it's actually something that'll work. But these are exactly the kinds of ideas that I want everyone in the audience to be thinking about when you're doing these procedures. When you do a procedure and you have this loop that's flopping around, think about, well, how can we make this loop better? How can we make it easier? How can we make it safer for the patient? All right, so now you can see how the loop opens, and I'm going to have you now just close it. You're just advancing the sheath forward. So that's just pulling it in to the sheath, right? This comes in like that. All right. Now the other device that I want to show you is on the left channel. Now there's no need to use double channel for this. And in fact, this was designed to enable you to do it just with a single channel, but it's a helix. I'm going to show it to you on the inside. And potentially we could just do everything through one channel. You want me to show it one channel? Dr. Puri told me that I have lots of time. Rajesh, is that still correct? Do I have lots of time to show you? That way I can show you all variations. What you need to understand is that we have a toolbox. We have different ways of doing things. There's no correct way. It needs to be customized for each patient. Sometimes you don't have a double channel, so you need to do the procedure with a single channel. So you need to have different ways of doing it. A double channel is really great because so this is an anchor, it's a helix, and it allows me to anchor. And one of the things I think we are lacking are anchors. Now, you saw yesterday the three-pronged anchor from Ovesco. Now, it was not designed as an anchor. Yes, as an anchor, but it was really designed to enable closure of defects where you could go in and catch the tissue deeply and pull it in. But the problem with that three-pronged anchor, it looks a little medieval, a bit barbaric. You're a little scared because those spikes turn upwards. And you saw yesterday how some of those spikes already had gone through the lesion on the mucosal side of that leiomyoma. So I don't think that three-pronged anchor is, in its current form, is the ideal way of doing it. Rajesh just walked in. Do I have time?
15 minutes is okay.
15 minutes. You said an hour before. No, that's fine. Okay. So we'll just stay with this. So I just want to show the audience all the different options. So this is a helix that's tied to a suture. And the whole idea is that you deploy the helix. You know the helix already from Apollo. There is a helix that is used. You saw the ESG yesterday, right? Maybe even today, I don't know. But you use the helix to pull the tissue. And then you get a pleat of tissue, and then you throw your needle across that tissue, right? So you have the anchor exchange catheter, and you throw the needle driver goes through, then you catch the tip, and you throw the needle basically back and forth. So that helix is kept inside the working channel, but you can't actually just, remove, you can't detach the suture from the handle. So this is just a modification that allows you to detach the suture from the handle. That's all. So let's go ahead and we'll just stick now with the double channel to show you, but you could do this also with a single channel because you can deploy the helix and then you can pull out, you have the suture in the working channel, and then you open up maybe we'll do it just with this scope. I can do it in 15 minutes. All right, let's do it. Okay. Because everyone doesn't have a double channel scope, even though I think everyone should. All right, so now we're going to go through our bigger channel here. Okay. So now you pretend this is a single channel scope. It needs to be a therapeutic scope, of course. You don't want to be doing this with a diagnostic scope, like the 1T. And so here's our helix. There it is. You can see inside the helix is at the very tip. You see it there? The coil? It's just a helix. Nothing fancy. Very simple. Simplicity is always virtue. All right, so now I'm just going to go inside. Patient's waking up a little bit here, needs a little bit more. Let's give some of that Buscopan now too. Okay. All right, here's our lesion, a lipoma. So let me just show you how we can deploy this. Well, we'll wait for her to calm down. We want the patient to be comfortable. Is this propofol we're doing? Now, propofol, good. All right. You can see she's talking to us. All right. So now what I'm going to do, so here, if you can have the camera also show what Assis is doing, okay? So wait. I'm going to tell you in just a moment. The first thing is just to kind of, we got to get her a little sedated though. Patient safety always first. And you never do a procedure with the patient moving. And so your anesthesiologist is your best friend. And anesthesiologists, by the way, never get the credit they deserve. They're the ones who keep our procedure safe. And back when I was in Germany, I was giving the propofol myself. And I can tell you today, that's inconceivable to me, that the endoscopist would be doing the anesthesia at the same time as doing endoscopy. That's crazy. And I also, as you know, USA is a very litigious society. So I'm also very happy that if there ever were a lawsuit, and most of the lawsuits are related to sedation, not to our procedure, thank God I'm not involved. It's the anesthesiologist I can point the finger to. So they have a lot of responsibility on their shoulders. So thank you. What's your name? Pankaj? Pankaji? Pankaji is our hero here. He's made the patient sedated. All right, now I'm going to push in now, and then I'm just going to rest this up against this like this, just gently. All right. Assis, I want you now, you're going to advance this forward. All right, good. Just advance it. And now you're going to turn here. Okay. Slowly turn, slowly. You want to drive it in, slowly, torquing. It's going to dig into the tissue. All right. Now it's already starting to twist the tissue a little bit, like that. And that may be actually enough. Okay. Why don't we stop now? And now all you do is you pull back. Pull back, and it dislodges it. Okay. Okay. What happened here? Where's the suture? All right, let me go inside and see. I don't know what happened. Let me look. There's supposed to be the suture that I'm pulling out. Well, folks, let me just pull this out and see what happened. I don't know. Maybe it somehow mal-deployed, or is there an anchor on there? Yeah, it didn't, for some reason, it didn't fire. For some reason, did you pull it all the way back before? Oh, you just give me another one. There's another one there. It's okay. So these are all in sort of their first stage of development. I won't call them prototypes really, but these are sort of, they've already been thoroughly tested, and I've used these extensively in animals. So let's give this another shot.
Can you explain what are you planning to do?
I'm going to retract this, and then I'm going to put the loop over the base, over the suture, retract it, and then I'm going to deploy the loop at the base. Okay, let's just try this one more time. I have to speed up since my hour became 15 minutes suddenly. Okay, can you hold the scope here like this? All right, so let's just give this another try. All right, so I'm up against here. Advance forward, please. Okay, start to rotate, please. I think what happened is it dislodged from the tissue, because, a lipoma is very, very soft, and it's kind of hard to engage a lipoma. That's I think, if this were a GIST, stromal cell tumor, no problem. Keep rotating because it's got to go a little bit deeper. I think that was the problem. It pulled out because I didn't go deep enough, or it's just hard for it to be. So I think it's in there now. Okay, good. And then stop. So let's try. So what you're doing now is you're pulling everything back. Pull this all the way back. And when it's fully back, okay. It's supposed to go click or something. And it's supposed to disengage. You can see how I'm able to retract like this. So the problem is, you can see, push it out, please. So I'm sorry. The problem is that I don't have a structure that's holding the loop firm enough for me to pull out to release the suture.
Dr. Binmoeller, can you hear us?
I'm sorry?
Can you hear us?
Yes, I can hear you.
Yeah. Is there any particular point in the polyp where you want to make this puncture, or it can be anywhere? Base or apex?
I'm just going to loop it now. It's really just to show you. And I'm unfortunately, I couldn't demonstrate it with this, but I will demonstrate it afterwards if we have time, just on the wall, because it's very safe. It just is an anchor. All right, so let's just loop this now because it's very easy to do just with the loop. But it just, you saw how with the anchor, I was able to pull it into the antrum, right? So I can't do that now, but we'll open up now the loop. So open. And what I'm going to need to do is to hook it enough so that I could get it around like this. Oh, I need you holding this, please. And I need to make sure I can swivel this all the way around it like this. And then now I'm going to pull back just a little bit. So this is where, you know, at the pylorus, your scope wants to fly back constantly. But I think this is, see how I got a nice stiffness? I think I'm at the base. Okay, I think I'm good. So now I want you to close, yes. So you're pushing that. So he's closing the snare, which has the loop on it. And I'm very angulated here, by the way. So this is where things get always a lot trickier when you have lots of angulation. Devices don't work as well then. All right, so now, is it done? Okay, now you're going to grab the thumb ring. You're going to pull it back, which is closing the loop now. Okay, so now the loop closes and it springs off of the snare, right? It detaches from the lugs of the snare. Okay, and once it's closed, now you're going to open the snare again, and then I just detach this and pull it off. And is the snare open? There it is. It's open. All right, good. Now I pull the snare back, close the snare. Just close the snare. So the snare served its purpose. There you go. So you have to remember that when you advance this forward, that closes the snare. You want to open the snare, you pull back. Okay, good. So now I can pull this back.
Dr. Binmoeller,
Yes.
Does this come like this, or is some sort of a homemade arrangement which we did? The putting on the loop onto a snare.
Yes.
Is something which comes pre-made?
Yes, it's pre-made. It's not. I didn't make this beforehand. It's already manufactured. Yes. Can I have some water, please? Just there we go. Well, that's a great idea. You know what? I love it. See, this is innovation. Now you've done it and you can save on your snare. Use the same snare to cut through. Ah, beautiful. All right. Yeah, we're going to name this device after you. All right. So now this is a snare. And you're right. We already had the snare. You just hook it up to cautery and you could use it. All right. So this is where it would be nice. Can I have something, the rat tooth forceps? Do you have one here? Now, one of the things I'm going to have to change is this loop here at the end is too small. And I definitely need a larger, I'm going to recommend that they make a larger loop here. So, because I would like to be able to pull on this when I throw my snare over it. That's the ideal way to do it. But I just don't know. It's a little difficult because these graspers are so thick. Open. We have one that's a little thinner, but you can see it can be a little challenging to get it in there like that. In the teeth. Close. Oh, see, I missed it. Open. And you could spend like an hour doing this. Close. Okay. Think I got it. Okay, 1 second. And then it just has to pull in like this. Okay. So now, that way I can just kind of pull that and just give a little bit of traction to look. And we'll hold this like that. See, I can pull it out like that. Just gives me a little bit. Now I'll open up the snare. All right. And then we just sort of get this snare. Do you see how violations it's become? It's really strangulated. You know, in theory, you could just leave this. And I tell you, in 2 weeks, it's gone. It will slough off. You know, that's the loop and let go method, which is just great. And by the way, sometimes I do this underwater too. So this is where you want to make sure that your snare is right above the loop. And so this is why I like having a little bit of traction there so I can kind of test to see. Do you see that the snare is not completely over the left side at the top? So I can see, is the snare all the way open still for me? Open? Yeah, fully open, yeah. Let me see here. Open. keep it open. Probably almost needed a little bit bigger. Okay, there we go. That's better. And just close the snare now for a moment. And let me see. The key is that you're not, we have enough stock. Actually, we still have some stock. This is why if I had given traction and closed the loop, it would have been down there at the base. That's how I wanted to do it. But that's the reason for traction, which you could do with a single channel if that anchor had worked. So I'm above the loop now. You see the loop is very tight. And this loop was specifically had the engineers also designed the loop so it gives a better, it's called the slip knot. Olympus calls it the slip knot. They didn't know that by calling it the slip knot, they were telling the truth. It slips. We don't want it to zip. So mine is called the non-slip knot because I don't want it slipping. All right, so now I'm going to cut this through. Okay. So this is when you're cutting this through like this. This is where you want to make sure that you don't, and it's off. So now the loop was there just to sort of, I wasn't above the loop enough. It came off because I was too close to the loop. And that's another reason why I like to have the loop really at flush with the bowel wall so that when I do my resection, my cutting, I'm at least maybe, I'd say 5 to 10 millimeters above that, 5 millimeters above when I close. That way you don't risk catching the loop, which can make it difficult to cut through, but at least you can cut through if you needed to. But also it just gives you, the ability to keep the loop in place after you cut. Because you don't know, I mean, there could be a vessel in there that suddenly starts bleeding on you. All right, so now this is the base of the area here. And so now the next question, I think, is what do we do about this base? Should we clip it? And I would say yes. I think we should just throw a clip. The best would be a nice wide-pronged one, like a 20. There's now a 20 millimeter clip. So a nice big clip. I don't know if we have those. Those are great. But we just throw a
this clip is to prevent prophylactic for bleeding, or you want the remnant to fall off?
Only to prophylact bleeding. That's all.
Okay.
That's why if the loop had worked and the loop were still in place, we'd be done. Right? We'd be done now because the loop is prophylacting against the bleeding. But since, I wasn't able to give traction and get the loop flush up against the wall, I unfortunately don't have the loop now protecting against future bleeding. So let's see if, what's this here now? This is, okay. So let me get rid of, I'm sorry, just open up I have to get rid of this. Forgot about this one. Actually, I could maybe pull this out. Yeah, there we go. Okay, good. All right, take this. And we pull this out and give me a clip. All right, now if Rajesh gives me just a few more minutes after I put the clip on, I can maybe show you how well the anchor. So the problem, it's interesting. I didn't realize that the anchor limitation is, what would have been even a better idea is through the double channel scope. I could have done this. I could have put a snare to catch the lipoma and pull it in. I should have done that. I realize that now. I could have caught the lipoma and I could have pulled it back and given traction just with a snare. You don't have to actually dig something into it, but the helix anchor was designed by, my thought was I want to be able to remove stromal cell tumors, cysts and leiomyomas, and I want to invert the wall. And then I can get a serosa to serosa apposition. And then I can either let it just slough off and enucleate, like yesterday you saw, and first I would do a cruciate incision to facilitate the enucleation. That's just, you need to open the mucosa up, right? So that the underlying capsule and just can enucleate. Or you can just go above the loop and cut it or ESD it. There are different ways to do it. You could put a snare right above it and cut it. That'd be very fast. Or what'd be very easy is just use an ESD knife, a dissecting knife, and just dissect above the loop. That'd be the other way to do it. So good. All right. Now here's the clip. What kind of clip is this? 16? Okay. So let's see if we can do this. Might be a little bit tangential, and the stalk's a little floppy, but let me get into position. This is, by the way, if you work in the bulb, you have to have a cap on. Otherwise, there's just no way. Even with a cap, it tends to flop back and forth. So the best way to do this is if I can get my assistant to help turn. He'll be cursing me in a moment, but I'm going to try to turn like this, okay? And then you hold it, turn, please. All right, let me see if I can do this. And sometimes it works and sometimes it doesn't work. Okay, here, open the clip now. And then we want to get it just really flat as possible. The reason is it's coming out at 6 o'clock. It would have been really hard to do it the other way. And maybe it'll work. And now hold that. My assistant is my hero. Okay. And suck in, it'll close. Just close it now. I sucked it in. Close. Did you close? Okay, just hold it there. Close. Don't deploy yet. I want to look and see whether I actually got it. We can. Oh, it looks great. Deploy. Yeah, deploy. Good. All right. Okay. See, everything is harder. Look, even the clip is hard to come off because of and there it came off. So when you're sharply angulated with your scope, you have to realize things are more difficult. Look, the reason why I know this so well is our biggest struggle back in the Axios development days with X-Lumina is every time we had the echo endoscope very angulated, we had all sorts of problems with our sheath, and the Axios would start to already deploy prematurely when we're pushing against resistance. And that's why it's so important never to push against resistance when you're doing an Axios procedure. So there we've got it. We can flush this off a little bit. And now if I have any remaining time, let me see if I can get the anchor. Can you just go in the room next door and grab another one of the anchors? Or just give me the anchor there, because I think the anchor still works. And, now that I'm thinking about this, we've done the job. And in a way, I sort of feel that to put an anchor in now is not necessary. And it's, so I think we'll just stop here because there's not an indication that I can justify, even as much as I'd love to show you and as much as I also would like to see, but I actually can't really justify doing it. First, do no harm, right? That's the motto of our practice. So there it is. And now I just get my specimen and I'll put my money on this, that it's a lipoma. So we'll just suck that up into the cap. Hopefully it'll come. Otherwise we have to get a Rothnet, but I'll just slowly pull this out.
Thank you, Professor.
Right, it's coming. Often you lose it right at the cricopharynx. One time it actually fell down in the trachea. So we don't want that to happen. Okay. 1 second. Not yet. You got it. Okay. And there it is. Look at it. There it is. There's our lesion. So I think it's, clearly we got the whole lesion, so it's all good. And there it is. And just flip it over to the other side. So at least what's important in endoscopy, it's the process. It's not really so much where the pedicle was, you see? It's not so much what you're doing. It's about the way that you problem solve. And
thank you, Professor.
We need really a treasure chest of devices, and
thank you, Professor,
that we can reach to and assist us customized, individualized to each patient.
Am I audible? Thank you, Professor, for a nice demonstration.